Welcome to Cardiology Keys, where we unlock concepts of clinical and scientific significance to anyone with cardiology interest. And today's key is disproportionate mitral regurgitation. The concept of disproportionate mitral regurgitation came into attention after the results of two conflicting clinical trials. Both of them were testing the use of mitral clip for the treatment of severe secondary mitral regurgitation in patients with heart failure reduced ejection fraction. These trials are named MITRA-fr and the COAPT trial. In patients with functional mitral regurgitation secondary to heart failure reduced ejection fraction, MITRA-fr showed no clinical benefit. Conversely, the COAPT trial showed significant benefit for all clinical endpoints. These are surprisingly contradicting results. So, what are the reasons behind these differences, and which one of these two trials should we believe? In order to understand that, we will need to review a few concepts. First, what is secondary mitral regurgitation? What is secondary mitral regurgitation mechanism? What is secondary mitral regurgitation relationship to LV geometry? And finally, how is secondary mitral regurgitation conventionally treated? The classification of mitral regurgitation is complex. The simplest version is classifying mitral regurgitation into acute or chronic. Acute mitral regurgitation is a surgical emergency and can happen in situations such as ruptured papillary muscle and ST elevation myocardial infarction. However, this is the subject of another discussion. Chronic mitral regurgitation, on the other hand, can be further classified into primary and secondary. The latter is also called functional mitral regurgitation. Now, we can list the causes of primary and secondary MR, or an easier way to put it is that primary MR is always the problem of the valve. That's why its treatment is almost always surgery. Secondary MR, on the other hand, is the problem of something else other than the valve, usually the left ventricle, and that's why in case of heart failure with reduced ejection fraction, guideline-directed medical and device therapy, or GDMT, is the treatment of choice in such condition. The two trials we spoke about before were more concerned with the secondary type. That's why a discussion about disproportionate MR is more related to that type of mitral regurgitation. The mechanism of mitral regurgitation in heart failure and situations with significant LV dilation depends on annular dilation and stretch. As the LV dilates, it puts traction on the mitral annulus such that the more the LV dilates, the more stretched the mitral annulus become, and the tethered leaflets move away from each other, causing a gap in between. The mitral apparatus function in that situation becomes abnormal, meaning while it opens and allows for LV filling during diastole, it will never close appropriately during systole. During systole, ejection will happen forwards across the aortic valve to the aorta, as well as backwards towards the left atrium. This mitral regurgitation happened through that gap that was created by the tethered mitral valve due to the dilated LV. Note that in this situation, the left ventricle empties during systole into two chambers, the high-pressure aorta and the low-pressure left atrium. The addition of that low-pressure chamber to which the left ventricle can eject blood makes left ventricle emptying exaggerated during systole. That's why left ventricular systolic functions measured by ejection fraction in these patients are not true representation of the status of myocardial contractility. In other words, a patient might have already developed systolic dysfunction or even become symptomatic despite that the ejection fraction value did not drop below cutoff limit that is considered normal in situations without significant mitral regurgitation. As such, it may be safe to conclude that there is a positive direct relationship between the left ventricular size and volume and the severity of mitral regurgitation, meaning the bigger the left ventricle, the more tethered the valve becomes, and the severer the mitral regurgitation gets, with higher volume of blood that regurgitates, also referred to as regurgitant volume. However, the relationship between the left ventricle and mitral regurgitation is far more complex than that. First, left ventricular volumes and ejection fraction are very load dependent and are inaccurate measures of LV functions. Second, and as we previously said, The relationship between the ejection fraction and mitral regurgitation is different than that in other situations, as the left ventricle is always hyperdynamic because of emptying into the low-pressure left atrium, giving a false sense of increased emptying and normal ejection fraction. More importantly, the relationship between the left ventricle and mitral regurgitation is a positive feedback mechanism, such that, as we just said, the more LV dilation, the worse the annular dilation and tethering, and then the severer the mitral regurgitation. But also, from the other side, mitral regurgitation itself causes volume overload, and that volume overload in the ventricle in itself will worsen the degree of LV dysfunction. Another source of confusion is that sometimes annular dilation happens despite that the ventricle is normal in size. That happens when the atrium is the chamber that is dilated. Sometimes when the atrium dilates, it also puts traction on the mitral annulus. If mitral regurgitation happens in this situation, we call it atrial MR. The relationships are even more complex than this. However, to simplify things, let's remember 4 factors that affect relationships in mitral regurgitation. Those 4 factors can happen in isolation or in combination and form a vicious circle that can start anywhere. The first one is the LV size and dilation in patients with heart failure reduced ejection fraction. The second one is the volume overload on the left ventricle that is exerted by the mitral regurgitation itself. The third one is the left atrial size that can increase despite normal left ventricle in situations such as heart failure preserved ejection fraction and atrial fibrillation. And the fourth one is the hyperdynamic status of the left ventricle because of emptying into a low-pressure chamber. The options available for the treatment of severe secondary mitral regurgitation include medical and device therapy, otherwise known as GDMT, or invasive interventions in the form of surgery, which can either be repair or replacement, and transcatheter edge-to-edge repair, also known as mitral clip. It's important to understand here that medical therapy or GDMT is the mainstay in the treatment of secondary mitral regurgitation, unlike all other forms of mitral regurgitation. While interventions in this case are options reserved to patients that don't respond or remain symptomatic despite maximum tolerated medical therapy. This is a figure showing the 2020 ACC/AHA guidelines for management of severe secondary mitral regurgitation, basically explaining what we just said. First off, medical therapy is the mainstay in treatment. Then, interventions are only reserved when there is no response to medical therapy. The guidelines also say that surgery should be done in patients not responding to medical therapy when the ejection fraction is above 50% or if they are going through another cardiac surgery, while mitral clip is reserved for patients not responding to medical therapy when the ejection fraction is below 50% and, importantly, when the mitral anatomy is favorable. The reason behind this 50% ejection fraction cutoff is that, remember, 50% ejection fraction in severe mitral regurgitation is not normal. It's believed that surgery carries special risk in severe mitral regurgitation patients with lower ejection fraction. Because after fixing the gap causing mitral regurgitation, the already failed ventricle will be devoid of the easier ejection into the left atrium, which remains a lower pressure chamber and becomes only faced with the higher pressure aorta, thus loses its deceiving hyperdynamic nature. As such, ejection fraction relationship to actual state of systolic dysfunction returns, causing a sudden drop in ejection fraction values once the mitral regurgitation gap is fixed. This may lead to acute LV failure, cardiogenic shock, and increased risk of operative mortality. That's why, if ejection fraction is below 50%, the less invasive mitral clipping becomes more preferred. I want to draw your attention that in this part of the mitral clip recommendation, specific parameters of the left ventricle are described for which the mitral clip should be done. This is where the guidelines refer to the main topic of today's discussion, which is disproportionate mitral regurgitation, and that was added as a result of the 2 clinical trials we spoke about initially. Remember that In the treatment of patients with severe secondary mitral regurgitation with heart failure reduced ejection fraction, MITRA-fr showed no benefit of using mitral clip, while the COAPT trial showed significant benefit. Looking at the differences between both these trials, we can see that, first, MITRA-fr's status of maximally tolerated medical therapy was questionable, while the COAPT trial used stricter inclusion criteria, limiting it to patients truly on maximally tolerated medical therapy. More importantly, though, compared to MITRA-fr, the COAPT trial included patients that had severe mitral regurgitation despite that their ventricle was not as dilated, indicating that in MITRA-fr, the degree of mitral regurgitation was expected from the degree of LV dysfunction, while in COAPT trial, the mitral regurgitation was severer than the degree of LV dysfunction, or in other words, disproportionate to the degree of LV dysfunction, hence the term disproportionate mitral regurgitation. Coming back to this figure, we already know that several factors contribute to the severity of mitral regurgitation. From this figure, we can understand that mitral regurgitation severity can be out of proportion of the degree of LV dysfunction. For example, if one or more of the other factors additionally contribute to mitral regurgitation. If that out of proportion mitral regurgitation is left untreated, it will eventually lead to worsening of LV dysfunction because it adds significant volume overload to an already failing ventricle. That's why probably treating this out of proportion mitral regurgitation will either contribute to reverse remodeling in heart failure reduced ejection fraction patients or save the left ventricle from getting into a worse condition because of volume overload. Despite the reasonable explanation to the differences between the results of COAPT and MITRA-fr, however, there are challenges that face the adaptation of the concept of disproportionate mitral regurgitation to clinical practice without further studies to test its accuracy. For example, the concept has been criticized for being largely dependent on assumptions, and also for ignoring the variability that exists in mitral regurgitation assessments using echocardiography. Also, for not accounting for the possibility of common calculation errors in the measurement of severity of mitral regurgitation, such as LV volumes, effective regurgitant orifice area, and the regurgitant volume. Having said that, we are all eagerly awaiting for the reports of studies underway, such as Reshape Heart Failure 2, that promises to shed more light on this concept. That's all for now, folks. Until we see you again in another video with another cardiology key, have a great day.